yes, it is possible for us to improve diabetes care in Africa and to provide a platform where people with diabetes can have an increased life expectancy like what we see in high-income countries.
Hi, Jean Claude. Welcome to the VI Diabetes interview series. It's great to have you.
Thank you so much, Olivia. Thrilled and happy to be joining you on this interview.
Would it be possible to give a brief overview of your career today and any highlights, perhaps, that you'd like to share?
My background is in general medicine, so I'm trained as a general medicine physician at the University of Yaoundé in Cameroon. After my training, I worked as a general physician for about 5 years. And during that period of time, I was seeing loads of people with diabetes. That really swayed my direction into diabetes research. Key highlights in my career, my Doctor of Medicine research program was in a diabetes and endocrine unit in Cameroon, that's in the Yaoundé Central Hospital. And I happened to work with some really phenomenal supervisors and mentors like Professor Jean Claude Katte, Professor Eugene Subgui in Cameroon. And during those days, you would have to do some really fanciful physiology of diabetes. We started looking at how to measure insulin sensitivity, insulin secretion, using clamps, using other short insulin sensitivity tests. And so that was really fascinating for me. I started noticing that I'm seeing lots of people with diabetes. Can something be done in this setting? That led to me leading the very first primary diabetes care unit in that particular semi-urban town. And this was set up in February 2013 with the help of the director and some other nurses. And this was a reference hospital for 22 other district hospitals. That meant we started seeing large numbers of people with both type 1 and type 2 diabetes. And I think that experience really just cemented my love for diabetes care and for diabetes research. When I went further to do my public health residency, it was really around organization of diabetes care. The second highlight for me was being exposed to the H3 Africa Consortium. This was funded by Wellcome Trust and the NIH in the US. And I happened to work at the time as the study coordinator for the diabetes project in Cameroon. And working within that network, being exposed to the vast diversity of research happening in Africa in diabetes was a very great highlight for me. Then the last one I would say was the opportunity to come over to the University of Exeter to do my PhD in medical science, which was of course lodged within the Department of Clinical and Biomedical Sciences and the diabetes team. That really was the epitome of career highlight.
I wanted to ask what motivates you on a daily basis to do the work that you do?
Seeing people living well with diabetes and understanding that diabetes is not a fatality. I've seen the worst of diabetes. You can imagine working in an African setting with low resources and seeing how diabetes can really be debilitating. But also knowing that with the right information and having the right resources, we are able to prevent diabetes from being a fatality. Being exposed to other settings, whether in Europe or in the US, and seeing the vastness of the facilities, the innovations, the technology with diabetes care further pushes me to say, yes, it is possible for us to improve diabetes care in Africa and to provide a platform where people with diabetes can have an increased life expectancy like what we see in high-income countries. One of my key motivations of why I do diabetes research within the African context is because I believe the innovation to impact ratio can be very high. What do I mean by this? Improving something even in just a small scale can lead to a very huge impact in the population, whether new ways of doing diabetes education, new ways of providing insulin, and just really understanding diabetes, research the biology better and knowing what are some of the best ways we can treat diabetes.
Your main focus is the etiology and survival of type 1 patients in sub-Saharan Africa. I wanted to know some of the key conclusions you've come to so far.
The mortality rate associated with type 1 diabetes in most African countries is still really high. Even with the advent of insulin donation programs, the mortality has reduced, but it's still really high compared to what we see in high-income countries. So what we have been, the way people present with type 1 diabetes can be really different in sub-Saharan Africa in terms of age of diabetes diagnosis, in terms of some group of people just going in and out of insulin treatment without necessarily developing diabetes ketoacidosis, cases of young people not developing severe diabetes complications, even though we knew that they were poorly controlled or not using insulin properly. Then we found that, yes, some of them really do have a typical presentation, whether in terms of the amount of endogenous insulin they are producing or with regards to some of them not having typical type 1 diabetes related autoimmune markers. Another key highlight we've found is that most of the kids that do go in and out of insulin therapy are able to do that because they have some form of high endogenous insulin secretion. So almost some sort of a natural selection where they are able to stay for long periods of time without using insulin, just because they have higher C-peptide or higher endogenous insulin secretion levels compared to others. We are beginning to see from our data that these endogenous insulin secretion capacity might be one of the key elements leading to whether children with diabetes in Africa survive with the condition or not.
You mentioned your young onset diabetes in sub-Saharan Africa study. Could you tell me a little bit more about what that study is?
This study was set up in 2018. One of the key highlights was that we were able to describe previously unrecognized subtype of diabetes within this group. Among the group of children and young adults with presumed type 1 diabetes, there were actually two distinct disease entities. Firstly, we had a group that had features of autoimmune type 1 diabetes, like what you would see in high-income countries. So they had the islet auto antibodies present, but strikingly, on the other hand, we found that the majority of these children and young adults with presumed type 1 diabetes had these really unusual immune and genetic characteristics. They did not have any of the islet auto antibodies. They were insulin deficient, but they did not present with the typical genetic markers of susceptibility that lead to type 1 diabetes. So we were seeing these two distinct groups. We think that this can be linked to the environment. It could probably be some sort of an infection, some medication, or something causing beta cell disease, leading to beta cell insufficiency, and probably linked to some form of genetic susceptibility as well.
Just to clarify, this is not the same as type 5 diabetes.
When the results were published last year, it was almost around the same time that the IDF announced the working group on malnutrition-related diabetes, which for the moment has been called type 5 diabetes. And there are some historic data from different African countries alluding to malnutrition-related diabetes as well. But most of that data did not look at very young age group like what we have in the YODA study. If malnutrition-related diabetes or type 5 diabetes exist within this group, then we expect that the way the disease presents would be different.
Maybe you can give us some high-level information about what type 5 diabetes is from what you understand it to be, as it's quite a new area, and we'd like our viewers to be able to sink their teeth into something.
The name type 5 diabetes is new, but the idea of malnutrition leading to diabetes is as old as anything else. If you look at some of the studies published back in the 70s or in the 80s from Africa, there was some talk about tropical diabetes, but later on it was removed because of inconsistent findings. The WHO felt the data backing malnutrition causing diabetes was not robust enough and consistent throughout. If you look at what was published back in the years, this was mainly reported in young middle-aged males who present with some form of insulin deficiency, but they do not go into ketoacidosis for some reason, and they lived in heavily deprived regions. Some of the data came from Ethiopia and in settings where they had long history of famine and generally less availability to food.
What do you hope to achieve through your research for the next coming years?
In the next 5 years, I'm looking forward to doing research that would lead to a better understanding of the pathogenesis of type 1 diabetes in native Africans living in Africa, because I believe that with all the development of type 1 diabetes research happening in the UK, in the US, and in other high-income countries, that our understanding will really not be complete if we do not know what is happening with type 1 diabetes in Africans. Because one way or the other, we are all Africans, right? If we believe in the common ancestor and the history of humankind. Secondly, pursuing these non-autoimmune insulin-deficient forms of diabetes that we are seeing in the majority of kids who are insulin deficient and have that presumed diagnosis of type 1 diabetes. And just to give you some scope, this new study is called PANDA. So PANDA study, watch out for it. The last one would be around improving survival. I strongly believe that, yes, providing insulin is good, but African governments need to take responsibility for the organization of healthcare in African states. I strongly believe that if we are able to better organize our healthcare system, we are going to improve the experience of people with type 1 diabetes in Africa and therefore the survival.
Thank you, Jean Claude. I really hope you managed to achieve some of those things. If there's anything we can do to support in any capacity, just let us know.
Thank you very much, Olivia. I'm really happy to be part of what VIA is doing, and hopefully we continue to strive for better diabetes care for less privileged populations all around the world.